Welcome to GU Oncology Now roundtable discussion focusing on prostate cancer, kind of the whole metastatic space, both hormone-sensitive, castration-resistant. I'm Jacob Ark with Urology of St. Louis, a large private practice group. I'll be moderating today's session, and I'm joined by expert panelists today that I'll let introduce themselves before we kick it off. I'll start with Dr. Finney.
Dr. John Finney, hematologist oncologist at Mercy Hospital St. Louis here in town.
Gautam Agarwal, urologic oncologist, also at Mercy with John.
Seth Strope, I'm a urologic oncologist at Urology of St. Louis.
Dave Bryan, I'm a urologist at Urology of St. Louis, so with these guys.
All right. Like I said, covering the spectrum of hormone-sensitive and castrate-resistant metastatic disease. Let's start just very basic, definition, how you get there. Dr. Bryan, what are you using to define that castrate-resistant disease in terms of labs, imaging? What are you kind of using to get there?
Sure. I mean, obviously, by definition, it's rising PSA with a castrate level of testosterone less than 50, usually on androgen deprivation therapy. As far as imaging goes, so back up, certain levels, depending on their mode of primary therapy. So we look for a level of at least 0.2, or after radiation, 3 consecutive rises. Mm-hmm. Also look at PSA doubling time, which, typically you'd like them to be more than 4 weeks apart. Mm-hmm. So, and then I use a lot of PSMA PET.
Yeah.
So.
Yeah, I think it's definitely helped. So, in the grand scheme of molecular profiling, we talk about germline testing, genetic testing. Does that have much of a role in defining between castration sensitive and castrate resistant, or management strategies on your treatments? Like, when are you using your germline tests, your genetic tests? How are you triggering those?
So anybody that's unfavorable intermediate risk or above, I try to get germline, or always prefer somatic if we can get it. If archival tissue is not available in somebody that may have had remote therapy, then germline, obviously. But then at progression, I like to use ctDNA, circulating tumor DNA.
Yeah. So. And Dr. Strope, any differences there from when you guys trigger maybe, like I said, germline, when are you getting it, somatic, ctDNA, et cetera?
For me, no, but I'm not really finding it much for the definition of the disease. It's for what I might do next.
Yeah, the management.
Management. Right.
In that resistant space. Right.
Yeah, I think I agree with what's been said. I think the field of precision medicine as it applies to prostate cancer is getting better and better. As Seth mentioned, we're not quite there where we can define disease with it too well, but I think we're getting there. Recently a colleague of mine, Adel Chowdhury, who used to be at WashU, now he's at Mayo Clinic, published a paper in the American Association of Cancer Research talking about cell-free DNA and being able to look at stemness. So the stemness characteristics of these cells in the DNA indicated kind of whether that patient's going to respond well or not to therapy, which could push them into saying, okay, this could be a person that very likely will be developing castration resistance and have a much more aggressive course of therapy. And it may lead us to that further discussion that we have later about how much do you add to their therapy up front while they're hormone sensitive. So the definition may not change, but I think it will change in probably the next 5 to 6 years about how do we say it's castration resistant. But it may not even be defined as castration resistant or castration sensitive. That may just go away, and we may just say it's prostate cancer with stemness characteristics indicating we should be highly upfront with our therapy or not. To the germline question, I think that's a great point because 10% of all malignancies are going to have some germline hereditary component. The more you test, the more you're going to find something. And it's not really just about the patient. There's a patient I had with stage 4 prostate cancer. He tested positive for ATM mutation, so it's a little lower in the realm of like BRCA versus that, but still put him at risk. Implications for his treatment were probably not huge. Could you add a PARP inhibitor possibly? With ATM, it's not as strong as with BRCA. But what was really cool about that case was we tested all of his kids, and his 3 daughters, one of them tested positive for ATM. So she got a screening mammogram earlier than she should have, and we found a stage 0 breast cancer in her, and she was cured. So it kind of has implications beyond just that patient. So kind of a cool thing.
Yeah. One thing, in risk stratifying who I'm going to do the different testing on, I'll look at their family history. All patients that are metastatic should be eligible for the genetic testing, and as you noted, unfavorable, so it makes a big difference. I was going to say the same thing you had noted. We've talked about at our conferences about the ATM mutations, not the response rates quite up with the BRCA patients, but we've been able to have, just with a nurse practitioner who focuses on genetic risk assessment, she's identified so many patients with these various genetic mutations, new ones that are being identified, has a lot of implications for treatment and for proactive family planning as far as screening. And so that's how I've seen that used, especially get their family history, and you can kind of see whether they're more likely to possibly have a mutation.
Yeah, I agree. I think as time goes on, the castrate-resistant status isn't going to be quite the same driver as it is now, because we'll have different targets at different data points.